If you're watching this video, then that means that Dr. Burt has diagnosed you with hip impingement and a labral tear. By now, you've tried conservative treatment options, including modifying what you're doing, taking anti-inflammatories, and physical therapy. At this point, Dr. Burt has recommended surgery to fix both your hip impingement and your labral tear. And so the goal of this visit is to go over everything to expect before and after surgery so that you can have the best possible outcome. After surgery, you're going to be on crutches full-time for 2 weeks. You can put about 20 pounds of pressure through your leg, so you can rest the weight of your leg on the ground, but you're not putting body weight through that hip. And that is to allow for healing, it's not for pain control. So even if you're feeling great, you want to stay on those crutches for a full 2 weeks, and then you'll slowly wean off of them over another couple weeks as your strength and gait gets back to normal. Most of the work is done in the front of the hip, so everything's going to be swollen and healing. So sitting upright and normal in a chair is going to be uncomfortable. So we do ask that you sit a little bit reclined just to give the front of that hip a little bit more space, but you don't have to lay flat all the time. We also don't want you bending that hip more than 90, and we don't want any sort of pinching in the front. The other thing we want you to avoid is external rotation for about 4 weeks. And so what that means is we want your toes and knees pointing up towards the ceiling. We don't want it rotating out or into that butterfly position. You can point and flex at the ankle. It's really just, again, that rotation out that we don't want. And so we do get you a hip brace after surgery, which helps prevent that rotation out. It also has a cold therapy ice pack unit built in. For things like sleeping, we recommend you sleep on your back in that hip brace. And if you tend to move a lot, tuck pillows or blankets on the side of your leg to help prevent those toes from going out and from you rolling over onto that hip. We had to start physical therapy about a week after surgery, and most people are in physical therapy for about 3 to 4 months to get back to their desired activity level. We limit any sort of impact, so no jumping or attempt at jogging for at least 3 months after surgery, and no higher level activities, including sports, things with pivoting, twisting, including golf, till closer to 4 to 5 months. Full recovery from this surgery is about 6 to 12 months. Risks of the surgery include risk of infection, as with any surgery. If Dr. Burt sees anything, you can get a little tingling on the side of your thigh. It's not very common, and if it does happen, the majority of those go away with time. Some people can get a little tingling on the top of their foot because we do put a little traction on your leg during surgery, but he's never had permanent foot numbness or sciatic nerve injury because that traction is monitored very carefully during surgery. There are reports of things like hip dislocations and fractures after this surgery, so if you have been diagnosed with osteoporosis or low bone density, make sure that Dr. Burt knows that ahead of time. It is a general anesthesia, so you do go all the way to sleep for it. So we'll review your chart ahead of time and let you know if you need to go to the hospital for any additional testing ahead of time to make sure that you're safe to put to sleep. Because you're not walking on that leg normally after surgery, that does increase the risk of blood clots. So we do place patients on a low dose 81 milligram aspirin twice a day, starting the day after surgery to help prevent blood clots. We also place patients on an anti-inflammatory, usually meloxicam, to help prevent something called heterotopic ossification, which is bone forming in the soft tissue around the hip, which can happen after this type of surgery. So both that meloxicam and aspirin, you'll start the day after surgery, and they do help a little bit with pain, but again, those other reasons are why we have you on those medications. You can also form scar tissue deep inside the hip, which can be a source of pain later on. So we order a machine called a CPM for everyone, and that just helps to move your hip in and out of surgery so that things don't scar stuck together inside the hip. If that's not covered by insurance and you can't get the CPM, you can use a stationary bike instead. So if you decide to do that, let Dr. Burt or his PA know ahead of time, and they can go over instructions on how to do that. For pain control after surgery, Dr. Burt usually sends in Percocet, which is oxycodone with Tylenol. It is a narcotic pain medication, so if you've had problems with narcotics in the past, or there's any reason you shouldn't take narcotics, please talk to Dr. Burt or his PA about that ahead of time so we can figure out a plan for pain control after surgery that's appropriate for you. Both the anesthesia and the pain medication can cause nausea and constipation, so we do send in medicine for that as well. I recommend that everyone just start the stool softener until you're going to the restroom normally and you're off of that Percocet. The other thing that we talk to every patient about is the potential for a procedure called a labral reconstruction. And that's in the scenario where if your labrum is too small or too damaged, Dr. Burt would put in a new labrum using cadaver or organ donor tissue. He'll have talked to you about it ahead of time if that's likely for you, but we do consent every patient for it just so he can do whatever your hip needs once we get in there. The difference with recovery with the reconstruction is that you would be on crutches for 4 weeks instead of 2 initially, and sometimes rehab's initially just a little bit slower because you have to build a little bit more strength back. Other common questions we get after surgery are when you can drive. So you definitely have to be off of any narcotic pain medication, and you have to feel like you can comfortably go from the gas to the brake and stomp on that pedal if someone were to cut you off. So usually right hips take a little bit longer than left, assuming you don't have a clutch, but I would plan on at least a couple weeks. If you have any other specific questions or there's specific activities you're wanting to get back to, please talk to Dr. Burt or his PA before surgery and they'd be happy to help you. Otherwise, our surgery scheduler will be in contact with you once insurance approves your procedure to schedule a date.